Well, it's a couple of minutes past the hour, so perhaps we can go get started. I see on the WebEx that the East Coast is well represented, so welcome to today's webinar of the Enforme Collaborative. And as you know, we do this on a monthly basis to share issues of common cause amongst professional associations with a focus on science and medicine. And today is a special webinar today, and I'm so delighted to have my friend and colleague, Dr. Bill Oetgen, presenting on the topic of maintenance of certification. And Bill and I have known each other for quite a while, and we were colleagues at the American College of Cardiology, where I got to know Bill, and we shared a lot of good work and opportunities there. So, Bill, I had gone through your CV. I had developed a very formalized introduction for you, but then I just noticed that you have your first couple of slides. You introduce yourself, and you do it far better than I could. So let me turn it over to you without further ado. The didactic portion of this will last about 30 minutes. We'll have time at the end for questions. I would ask those of you who are not speaking to mute your phones so that we have as much audio clarity as we can as we are recording this session. So without further adu, Dr. Oetgen.
Well, thanks very much, Kevin. It's really a pleasure for me to participate in this webinar. Kevin mentioned this to me about a month ago, and it's been something that's been on my mind, and been looking forward to it quite a bit. So it's here, and let's go ahead and get started. As Kevin mentioned, I'm Dr. Bill Oetgen. By way of background, I am board certified in pediatrics, although I have not practiced pediatrics since the late 70s. I'm also board certified in internal medicine and in the subspecialty board of internal medicine of cardiovascular disease. I am also participating in maintenance of certification, which I think it's important for you all to know, and also that I am loving it. I am having a wonderful time doing the things that need to be done to participate in the maintenance of certification program for the American Board of Internal Medicine. And the reason that I am loving it is that it's an opportunity to relearn old things that I knew one time and have forgotten because I haven't used them, and also an opportunity to learn new things because so much has happened in the last 10 years or so since I have not been in active patient care. So it's quite fascinating and interesting, and I've been enjoying it quite a bit. I'm also, Kevin has alluded to our association with the American College of Cardiology. I'm a former executive vice president, as Kevin is, and I was the EVP for Quality in Science, Education, and Publication, which are the three main member-serving and outward-facing divisions of the college. I'm also a board member and immediate past chair of MedStar Health, which is a 10-hospital integrated health system here in the Washington and Baltimore area. And also, as been previously mentioned, I'm a former executive team member at the ACC with Kevin. And if you don't believe that, I have photographic documentation of that. In the next slide, on the left there is our executive team retreat in 2014 in Moab, Utah. That's day one. On the left, day two is on the right. It's with Kevin and our colleague Kathy Gates. It looks like it was just right before we started the mountain bike episode because I think we didn't look quite as good after the episode, but there we are in Moab.
You were kind of bloodied after that.
Yes, we were literally bloody. Yeah, that's exactly right. You can look at our legs and see that we don't have any scars or running sores. So this was a pre-event photograph. Good time. We did a lot of fun things out there. Learned a lot about ourselves, learned a lot about each other. So let's go on. Let's jump in. Why maintenance of certification? And what I'd like to do is to start to have this discussion in kind of a little bit of a historical concept to kind of put things in perspective. Starting back in medieval Europe, from the 5th to the 15th century, our medicine as a profession really has its basis in the guild system, which, as you probably remember, were groups of skilled laborers who underwent periods of apprenticeship before they were fully participating in their trades. And you can kind of see how that residual characteristic is present in the training of physicians these days. In the 17th century, excuse me, a London apothecary named William Boghurst, who was dealing with the Great Plague of London, has this very interesting quote: "Every man that undertakes to be of a profession or takes upon himself an office must take all parts of it, the good and the evil, the pleasure and the pain, the profit and the inconveniences all together, and not pick and choose. For ministers must preach, captains must fight, and physicians attend upon the sick," beginning the idea of a profession. Then 2 centuries later, in early the 1800s, Thomas Percival, who was an English physician, published Medical Ethics, a volume in which he described medicine as a profession and as a public trust. Now, medicine as a profession is something that we think about on a routine basis, particularly in medical professional societies. I think that's kind of the fundamental concept that we work from. And I think that for those of you who may want to dig into it a little deeper, I would recommend Paul Starr's Social Transformation of American Medicine, really published in 1982, which is a kind of a required reading, I think, in folks who are in the medical professional association business, because it really puts things in a proper context. In that volume, Starr defines a profession as having 5 elements. 1, required training. 2 is a collegial discipline. It's also called self-regulation in other contexts. Number 3 is a base of knowledge, and that also has been called a learned practice. It's mainly focused on service, not profit or motivation, and it is governed by a code of ethics. And my next slide, which sort of covertly snuck in there, highlights the concepts of self-regulation and base of knowledge as important parts of the definition of a profession, which we're going to go back to in a little bit, so we'll remember those. Early in the 20th century, the public regard, at least in the U.S., for medical practice was quite low. This was a time, as you think back, the time of quacks and snake oil salesmen and lax medical education and the purchasing of medical degrees and no regulation at all. But in 1910, the society had the benefit of the Flexner Report, which documented the poor state of medical education in the United States and really stimulated multiple state laws and multiple closures of proprietary medical schools and a creation of a model of a medical education which really survives 100 years later to today. That was the Flexner Report. And soon after that, 3 organizations, this is in 1914, 3 organizations created a joint committee to evaluate the education of physicians who were claiming to be ophthalmologists. And these organizations are American Academy of Ophthalmology and Otolaryngology, American Ophthalmological Society, and the Section on Ophthalmology of the American Medical Association. These three groups got together and formed the boards that are listed right below: American Board of Ophthalmology, the American Board of Otolaryngology, American Board of Obstetrics and Gynecology, the American Board of Dermatology, which was called the American Board of Dermatology and Syphilology, in those particular, in the order of the years that I have on the slide. Then in 1933, the four founding organizations, the four founding boards came together and formed an overarching organization called the American Board of Medical Specialties, which continues to today and is now the governing board of the specialty boards. And well, I'm just going to go quickly through a kind of a chronology of when these boards were created and founded, and the numbers behind the boards are the numbers of specialties and subspecialty disciplines that are currently being supported by these and evaluated by these boards. So, for instance, in orthopedic, in 1935, there were 5 boards that were created. The orthopedic surgery now has 2 primary certificates. Pediatrics has 20 subspecialty certificates that it offers. Psychiatry and neurology has 3 primary subject certificates and 15 subspecialties. Radiology has 4 primary and 5 subspecialty. Urology has 3 primary. Internal medicine has 20. Pathology has 3 and 11. Surgery 2 and 5. Neurologic surgery only has 1. Anesthesia has 6. Plastic surgery 2. 1947. Physical medicine and rehabilitation came online. They have 7 subspecialties now. 1949, colon and rectal surgery. Preventive medicine has 3 primaries and 4 subspecialties. Family medicine came on in 1969. They have 6 subspecialties. 71, allergy and immunology, nuclear medicine, thoracic surgery. Emergency medicine, 79, and then finally the last one to join the ABMS is medical genetics and genomics, and they have a number of specialties and subspecialties. You add them all up, there are 24 boards that provide 36 primary certificates and 134 subspecialties. So this is a vast, highly complex set of organizations. There are 9 subspecialties that are actually represented by multiple primary boards. For instance, hospital and palliative care is represented by 10 different boards. It's a subspecialty of 10 different boards. Pain medicine 6, sleep medicine 6, sports medicine 6, and critical care 5. So you can see how there's multiplication, there's interaction, there's duplication among, not within a board, but among across the board. So it's a vast network of offerings and experiences. Now, an important fact is that most boards, when they started to provide board certification certificates, these were lifetime documents. There are some exceptions. Family medicine and I think genetics did not. They had they had time-limited certificates that they issued. But in the late 80s, folks began to look at this, and they looked at lifetime certificates, and these came under questions. And the questions were pretty straightforward, just what we would think. Did a lifetime certificate make sense? Did knowledge and skills remain constant, or is there a predicted attrition of knowledge and skills over time? Why, for instance, are fully certified airline transport pilots retested every 6 months on their skills and knowledge, and doctors have lifetime certificates of competence? Does that really make sense? Is that what society is looking for in the social contract with physicians? And then in 1999, a very interesting study came out in the psychology literature that highlighted what's called the Dunning-Kruger effect. And that's basically that people don't know what they don't know. That people, and the title of the article was Unskilled and Unaware of It, How Difficulties in Recognizing One's Own Competence Lead to Inflated Self-Assessment. So the Dunning-Kruger effect makes us worry that perhaps we as practicing physicians don't know as much as we think we know and don't know that we don't know it. Here are a couple of graphs from the original Dunning-Kruger paper, which are very interesting. They presented 4 experiments that they used to test their hypothesis. One is on humor, another on logical reasoning, another on grammar ability, and another perceived logical reasoning ability and as a function of performance test and actual performance. And as if you look at all of these slides, all of these graphs, they have a very similar picture, and that is there's a line that's a diagonal line that's actual test scores, bottom, second, third, and fourth quartile, and then there's a top more solid line that is what the participants' perceived ability is before the test. And what you can see is that uniformly, the people who are the subject of these tests, particularly if they're in the bottom quartile, they thought they knew a heck of a lot more than they did. And as you moved up toward the top quartile, there was a consistent underestimation or underassessment of what people did. So the less you knew, the less you knew you knew. And the more you knew, the less certain you were of it. And it's an interesting documentation of how, of the psychology of this particular issue. So during this time in the 90s, 80s and 90s, the questioning of the appropriateness of lifetime certification led the ABMS to recommend to its member boards that they changed policy to time-limited certificates. And they went through several phases. One was a recertification phase, and there was some modification of that in terms of what the physicians had to do. And then finally they settled on this concept of maintenance of certification, which has 4 parts. Number 1 is licensure. Basically, you have to have a functioning license to practice medicine. Part 2 are ongoing educational activities analogous to continuing medical education activities. There's a secure examination, the tenure exam, and number 4 is our practice improvement activities, which is the board that I'm certainly most familiar with. These MOC changes became fully operative in 2014. The reaction from the profession, that is from the members, from the diplomates, was swift and mostly negative. And at the ACC, we noted that there were 2 phenotypical expressions of this reaction. The first, we reminded us of Cool Hand Luke and Paul Newman, and we call them the Lukes. And the second reminded us of John Rambo, and we call them the Johns. So here's the difference. The Lukes saw value in maintaining the ABIM certification. They were not inclined to follow other paths, such as the National Board of Physicians and Surgeons, or starting a new board. They do not particularly like the Part 3 requirements. That's the secure examination requirements. But they were reasonably quiet about it, and in terms of the ACC, they supported negotiating with ABIM for a solution to the Part 3 problem. The Johns, on the other hand, were of a mind that the ABIM was corrupt and venal, and the ACC should have nothing to do with it. ACC members should go with NBPAS, the alternative board, or the ACC should start a new board, a new cardiovascular board altogether. They didn't like any MOC requirements. They were very vocal, and they supported giving the ABIM an ultimatum and walking away. The ACC board, considered all of these things, and particularly was not enamored of the idea of starting a new cardiovascular board, because they realized that to have a board that was credible at all, not everybody could pass all the time. And so the ACC did not want to be in the position of having to tell a member that they didn't pass an ACC examination, because the fear is that soon after that happened, the person that got that news would no longer be a member of the ACC, and that would not be in anybody's interest. So the idea was to try to continue to have the ACC function as a medical professional society with an education focus, and to figure out a way to work with the ABIM to be the assessment and evaluation organization. There were some additional arguments against MOC that we heard, one of which was, most of this is irrelevant. I know what I need to know. And to that, I would say, see the Dunning-Kruger effect. Probably that's not the case. Number two, this is too expensive. And an interesting little tidbit occurred while we were in the process of discussing all of this. An ACC governor from Washington State, I believe, calculated the cost for MOC and the cost for having a Starbucks latte once a day, and it came out to be pretty much the same number. So it didn't seem that it was all that expensive. And number three, I do CME, and that's good enough. And it's certainly true that CME is sufficient for licensure in most states. Not all states require CME, but most of the states require CME for licensure. But that's a very low bar. Anybody that's been to medical school and done an internship and does 50 hours of CME per every 2 years can practice medicine, for instance, in the state of Maryland. But that's not quite the level of expertise that we'd like to see if we're having crushing substernal chest pain and find ourselves in the emergency room somewhere. We would like to have specialty care, subspecialty care, and we'd like to have a higher level of acuity. And I think it's reasonable to say that folks with that level of training and that level of acuity, who treat that level of acuity, should answer to a higher level of standard, which is MOC, as opposed to CME, which everybody can meet. So right now, I think it's fair to say that the most vexing problem of MOC is the 10-year comprehensive examination. What should be done with that? The ACC came up with a solution, and it's designed to meet the two of the important obligations of a profession, which I mentioned earlier, and that is to define the base of knowledge and to achieve self-regulation. We want to be able to do this within the medical profession and not have it done, for instance, by state legislatures. What the ACC did was create and deploy a self-assessment based collaborative maintenance pathway, which was self-study, self-assessment. It's a modular year program to review and be assessed on all of general cardiology. It satisfies the needs of all the ACC members, the Lukes and the Johns. It's been highly popular in 2019 among ACC members and others who have sort of purchased it off the shelf. And in 2020, the college will publish self-assessment programs and collaborative maintenance pathways for heart failure intervention and electrophysiology. parallel effort, the ABMS has come up with a solution. They've created a vision commission on continuing board certification, which was inaugurated in 2018 and which presented its final report in February of 2019. They've identified 5 task forces which are actively engaged in the topics noted: advancing practice, that is, finding practice environment changes to support learning and improvement activities; information and data sharing between member boards and key stakeholders like medical specialty societies; professionalism, looking for ways to evaluate professionalism, which could be a dangerous path for them to go, and many of us have advised them against that, because professionalism is virtually impossible to measure in an objective way. So it'd be tough to evaluate. Remediation, that is to try to find pathways for remediation of certification gaps. And then standards, that is to develop new continuing certification standards, which are different perhaps from the current certification standards or maintenance standards that most boards are dealing with now. So a lot of changes have occurred, particularly since 2014. The ABMS has taken a proactive look into the future and trying to define a reasonable pathway to preserve the value and the meaning of the board certifications that are issued by their member organizations. Where it ends up, we don't know. It's to be determined, but it is clearly a point of intense interest in a lot of very dedicated folks. So it will be evolving, and we'll keep you informed. So with that, thanks for the invitation, Kevin, and I'm happy to help with any questions.
Well, thanks, Bill. That was a great survey of what's been evolving now for a while. This has been a very contentious issue, and it shows no sign of coming to a neat resolution. Although the difference between the commercial airline model and the medical model is just such a vast gulf between them. Are there other professions, Bill, that have similar types of continuing recertification programs?
Yes, quite a few. The one that comes to mind are nuclear engineers who also function in a very high-risk environment. Others not so high risk, but quite important. The requirements for accountants are fairly strict. Lawyers have their bar association educational requirements. I think they're not as technically demanding, I think, as what we see in maintenance of certification. But the concept of having professionals continuously learn and document their learning is not foreign at all to modern society.
One more question from me, and then perhaps there'll be some questions from the attendees. But what can professional associations be doing in the interim as we come to some resolution on the MOC issue? How can professional associations serve their membership, meet these educational needs in the meantime?
Well, I think two things. I think that the professional societies really need to continue what they're doing very well, which is to provide educational opportunities for their members and to use their members to find what knowledge is needed and what's necessary to practice in their particular specialty. And so that's one thing, and that's something that professional societies have been doing well for a long time. Another thing, I think, is to remind the members that, this is this is a profession, and as I mentioned on the slide, we have an obligation to define the knowledge base and to acquire the knowledge base, and then to self-regulate in terms of being able to document for society that we have achieved and are continuing to achieve and maintain a certain level of knowledge so that we can provide high quality care for them. So those are the two things, I think. Remind the members of the obligation of a profession and how we can achieve that, and also continue to develop very high quality educational opportunities for our members.
That's great, Bill. Thank you for that. Questions from the attendees?
Hi, Bill. This is Darrell Hunter. Thank you for that very illuminating presentation. As I am new to this area, I'm learning more about folks, the professional community, staying up on their education. Currently, again, what do you see as the gaps in regards to this way of them to self-regulate themselves? What are the 2 or 3 things that are happening that you feel that should be addressed immediately?
Well, I think the thing, the immediate thing is to try to dampen the enthusiasm that some folks have for going to state legislatures and getting legislation that that precludes the use of maintenance of certification for hospitals in their credentialing process and for insurance companies in their credentialing process. The idea that that maintenance of certification should not be used for that is an erroneous idea, and it's a dangerous one because it opens the door for the state legislature to say, well, if this is so horrible, which is, by the way, being done by physicians for physicians, but if this is so bad, then we'll do it. We'll take it over, and then the next thing you know, because members of the profession have found this somewhat onerous and have wanted to do away with it, they will find themselves, and we will find ourselves, in a much worse situation because we'll lose the autonomy of our self-regulation and self-governing. So that would be the single most important thing. It's a hard thing to argue for because the people that hate MOC, and they hate being told what to do, and they think that getting rid of that is the single most important thing. But actually, it's a step in the wrong direction. So it takes a lot of education.
Hey, thank you.
Thanks for that question. Any other questions? Well, hearing none, Bill, I want to thank you for your time and your generosity with your expertise, as always. We have taped this session. It'll be available on the Enforme website shortly. And if you think that any of your colleagues would benefit from reviewing this material, it'll be available for free for the community. So thank you all for attending. Thank you, Bill, again, for your generosity.
My pleasure.
And I hope everyone stays safe and healthy through this uncertain time that we're in. With that, we'll conclude for today. Thank you all very much.